Hello, I'm Marsha, a this Institute PhD Fellow with the University of Hull and a palliative and end-of-life care nurse at Guy's and St Thomas's Hospital in London. Today, I will be talking about why personal values should inform models of value-based healthcare for an aging population with multiple conditions. Globally, more people are living longer with chronic conditions such as heart disease, dementia, and diabetes. Disease-specific projections show that deaths from dementia will almost quadruple, from just under 60,000 to almost 220,000 per year, and an extra 65,000 people will die from cancer per year by 2040. Dementia and cancer will be the main drivers of increased need, increasing demands on palliative care services. The course of illness for older people with multiple conditions is different in terms of illness severity, how long they live, their personal priorities and preferences. With medical advances, more treatments are offered, sometimes with limited benefit and little or no consideration of what is most important to the person being treated. Older persons often prioritize function, comfort, or family support. There remains unwarranted variation in outcomes of care associated with healthcare professional decision making rather than patient diagnosis or preferences. I recall caring for a retired lecturer who was diagnosed with an advanced brain tumor. She had high blood pressure and later type 2 diabetes due to medications used to treat her symptoms. Before diagnosis, she loved singing, traveling, and was fiercely independent. She received several rounds of radiotherapy and chemotherapy, spending a lot of time attending for treatment, tests, and coping with side effects from treatment. As her disease progressed, she required 24-hour care and was admitted to a nursing home. She became tearful, frustrated, and low in mood at her loss of independence and autonomy. She expressed regret at accepting treatment and felt her decisions would have been different had she known the potential outcomes of her choices, highlighting the complexity of managing multiple conditions in healthcare. Palliative care is an approach that improves the quality of life of patients and their families who are facing life-limiting illnesses. It prevents and relieves suffering through early identification, detailed holistic assessment, and treatment of pain and other problems to help patients live as actively as possible until they die. Palliative care supports the patient and their family as a unit of care, offering emotional and psychological support to carers. Older patients and their families desire control over health decisions when living with serious illnesses. Because of higher rates of cognitive impairment, there is greater dependency on surrogates to make decisions. Healthcare systems, including palliative care, must adapt to the needs of an aging population with multiple conditions to improve the outcomes of patients and families. One such approach is value-based healthcare. Porter and Teesberg proposed value-based healthcare as the strategic framework to improve services for patients by simultaneously addressing outcomes that matter to patients, as well as the associated costs. In the past 2 decades, there has been a remarkable upsurge in implementation in numerous countries, including the UK. Policy initiatives and payment models are being influenced by this framework, now largely considered the blueprint for promoting sustainable approaches in healthcare. This framework defines value under 4 pillars: personal, technical, allocative, and societal. There is limited evidence that personal values, beyond a monetized definition, have been included in models of value-based healthcare, despite their inclusion being recommended by the European Expert Panel on Effective Ways of Investing in Health, thwarting the aim of the framework to deliver care that matters most to patients. Personal values are described as the principles that guide us throughout our life, motivate how we behave and the choices we make across present and future situations. Values are shaped by an individual's own experiences, religion, culture, society, and institutions, and guides what is seen as most important. Personal values have important consequences for behavior in healthcare, as individuals tend to make decisions that align with their values. Though not always consciously thinking about them, values play a central role in practically every aspect of life that requires a decision. Values such as independence, autonomy, and tradition influence patient and family decisions about what treatments are accepted, adhered to, and which services they engage with. Values span cultures, but sometimes vary in priority. For example, Autonomy is highly prioritized in Western society, and treatment decisions are made by individuals based on their personal values and the information available to them. They choose whether to involve family. In other cultures, tradition is prioritized and decisions are made by an elder or the family unit. As ethnic diversity, disease patterns, and aging of the UK population changes, personal values and prioritization of these values may change. Understanding the conceptualization of personal values of older patients with multiple health conditions and their influence on healthcare choices is paramount to improving care and outcomes. In the case of the patient I referred to earlier, understanding her values and offering treatment aligned with them may have led to better outcomes for her. Current evidence focuses on value from the view of funders and healthcare professionals, not patients, although categorized as important in the literature. Healthcare professionals' views of value and those of patients and families often differ, contributing to the overuse and underuse of healthcare. National voices championed the importance of what matters to someone, not just what's the matter with someone. Personal values of patients with advanced illness and their carers receiving palliative care is poorly understood and often not utilized to inform care provision. The understanding and conceptualization of personal values from the patient's perspective is vital. My PhD study is focusing on personal values of patients in the context of the widely adopted value-based healthcare framework. My study aims to understand the personal values of patients living with multiple conditions and/or advanced illnesses, and those of their informal carers, and how these values influence their healthcare priorities and choices. This knowledge will inform a co-produced conceptual model of value-based healthcare for older populations with multiple conditions receiving palliative care. An exploratory sequential study design is being adopted as there is limited evidence on the personal values of this population using palliative care services and in the wider context of value-based healthcare approaches. This design uses a step-by-step approach where each phase informs the next. The systematic literature review and PPI consultation in phase 1 informs the patient and carer interview guide in phase 2. Both phase 1 and 2 findings will be integrated to inform the initial conceptual model for presentation at the workshops in phase 3. The 4 study sites are a mixture of NHS hospital and voluntary sector hospices, providing care in community and inpatient settings. The sites have been selected to include rural and urban organizations providing care to multi-ethnic and older white British populations to provide a broad contextualized understanding of personal values in palliative care. My recently completed systematic review explored the extent to which patients' personal values are incorporated into value-based healthcare models in existing evidence. The applicability of these models for people with multiple conditions and/or advanced illness and their families is being assessed. Outputs from the consultation exercise held with PPI partners in this phase inform the interview guide to be used for patient and family carer interviews and shaped the study design to maximize carer participation in phase 2. Here, individual face-to-face and remote interviews will be conducted with patients and family carers separately to explore how they understand personal values and how these values influence their healthcare choices. Demographic information will be collected to monitor purposive sampling and contextualize study findings. Interview data will be analyzed using discourse analysis. Discourse analysis is a qualitative research method that lets us see how people's words reflect their values and the social context around their values. Data will be categorized into themes and patterns relating to personal values alongside social and historical context. These findings will be integrated with phase 1 findings to inform the initial conceptual model for presentation at the first workshop. In this phase, I will conduct 2 online workshops with PPI partners, healthcare professionals, and policymakers from the participating sites. In workshop 1, I will share the integrated findings from phases 1 and 2, along with the initial conceptual model for discussion and feedback. Workshop data will be analyzed using thematic analysis as outlined by Brown and Clark, and the final themes will be used to refine the initial model. The revised model will be presented in Workshop 2 for feedback and final comments and further refined. Acceptability, barriers, and enablers to implementation of the model will also be explored across both workshops. Once completed, I will have a co-designed model of value-based palliative care that reflects what matters to patients and their carers to inform care and service provision.